All right. Well, welcome everyone. Welcome, welcome. I know we've got people joining now. I'm Chelsea. I want to welcome you to our panel discussion on advancing treatment for people. On the title it says severe and long-standing eating disorders. I'll just say people with eating disorders, people with eating disorders who have been struggling to get better in a FOD system for a really long time. So I want to welcome you all. I want to let you know we've got a chat open. So if you want to tell us where in the world you are joining us from, if you're here live, that would be great. I'd love to know. And we have a helper here, Melanie, who's going to help me keep an eye on the chat for questions. So our intention with this is to hear from you all and hear some questions. So please do, even as we're speaking, if a question comes up, feel free to drop it in the chat and I'll try to get to it, even if not right in that moment. So just I want to introduce our panelists. And Mel, could you help me spotlight Dr. Ayton? That would be great. But just before we kick off, just to set a frame for this, I'm Chelsea. I'm in my day-to-day work. I'm the founder and the director of Eat, Breathe, Thrive,
So we
which
have that
is
post there.
a nonprofit in the
Now
US.
we
We operate
also
as a
have to
charity
recreate
here
the
in the UK. I
post
live in London, helping people
um,
to recover from eating disorders. That's
in DCSD
our
news.
day-to-day work. But
So we're
how
gonna
we
do
came to
that.
do this event,
Create.
I
We're gonna
do
clone another
work in
post
research
like
on
I
the
did
side,
before.
and my co-author, Dr. Catherine
Um,
Cook-Catone, and I recently published a
Copy the
study on
title
assisted
once
death
again.
in eating disorders. And so the purpose of this
Update that
conversation, and we're doing a
URL.
series of conversations as part of our Treatable Not Terminal campaign, is to generate
And
conversation about
then
some of the incredibly
I had actually
complex,
just copied
nuanced,
that. We're going to keep that learn
challenging,
more in this
difficult,
one
sometimes
now so that people
heartbreaking
can be
topics
directed to the
that
principal
that
profiles
study
page.
uncovered.
Sometimes you still need
And
to
they
do
are
a little bit of
complex.
extra
We have
styling.
a joint statement out
Gonna
that
remember to
is
put that sentence
asking,
in the
well, we've
summary
invited
here.
organizations and individuals to
Put the start date
uh,
as the 23rd.
take a stand to prevent assisted suicide in people with
And
eating
again,
disorders. But I'm so aware
we're
a
going to
joint
use that same
statement is, a
photo.
page, two
So
pages
it
at
should already
most,
be
and you can
uploaded.
only dig into the
Here we
nitty
go.
gritty in so much. So that's really the purpose
People on a
of this
Hulk ride. All
conversation.
right.
And
I'm going to click
our hope is
update
that
there.
in this conversation, we can shift the conversation a little bit
All right.
away
And now we're going to
from
cross our fingers that it
death
shows up everywhere that we want it to.
the terminal anorexia
So
conversation
now
and
hopefully
to
that should
what
look a
people
bit
really need
better. There we
to
go. All
recover.
right, but
So
of
on
course, as
that
always,
note, I want to
reach out to me with
introduce
any
you to
questions.
the
I'm also happy to do
incredible
this. It's super quick,
humans that
so
we
hopefully
have
this
here
video was
from all
helpful.
over the world to have this conversation. And I'm going to start. There's no particular order other than how you are on my screen. So Ali, you're first at the top of my screens. Do you want to introduce yourself?
Yes, certainly. Thank you very much. So I'm Ali Ibrahim. I'm an eating disorders psychiatrist. I'm very pleased to be here, and I'm pleased that you've started off with a positive note of let's try and kind of have a conversation about treatments and what it is that we can do and how we can change the narrative. I think that's really important. Um, right.
Excellent. James.
Hi, I'm James. I am somebody with lived experience of anorexia and bulimia. I think having had a severe long-standing eating disorder, I've learnt a lot of things about what I think might help people. So that positive framing again, but some of that learning has been through seeing things that are unhelpful. And I think that we can learn from the difficult things in this conversation as much as we can from, evidence of things that work that are more common in other areas.
Excellent. Lorna?
Lorna, I had an eating disorder for many years and was a revolving door patient. But I'm out the other side now, and I can say that because I live my life and I do really exciting things. I'm an artist, writer, filmmaker, a researcher, lots of things. I have many hats. So I'm not quite sure exactly which hats I'm bringing today, but we'll just make it up. Okay.
All of them, we hope. Thank you, Lorna. Anita?
I'm already loving being on this panel. My name is Anita Federici. I am in Ontario, Canada. I'm a clinical psychologist. I've worked in eating disorders for 25 years now. and spend most of my time focusing on advocating for system change. And so this is a really, really near and dear topic to my heart. So I'm glad to be here. Thank you.
And last but certainly not least, Agnes.
Hello, and thank you very much for the invitation. So my name is Agnes Eaton. I work in the UK. I am an international medical graduate, so I started my career in Hungary, and it's really quite interesting, the international differences between prevalence and treatment and attitudes. And I have been specializing in eating disorders for about 25 years as a consultant. And I always worked with the extreme severe end of the spectrum. So I always worked in hospitals. And I know, I think, but certainly I worked together with Ali, with James and Lorna on various things. And I suppose one more thing, I need to mention that I'm speaking as an individual rather than representing any particular body today.
Excellent. Thank you for that point of clarity. And I didn't realize you were from Hungary originally, so we really do have some international perspectives here, which is really exciting. I want to kick us off with a question that I know James will love, because James loves language, as I do. But it's about language. And just context for this, one of the things that kind of was unexpected in the study that we did is we noticed that often when assessors or physicians were giving justifications for why someone was eligible for euthanasia or assisted suicide, someone with an eating disorder, they cited a kind of a diagnostic. You can't call it a diagnosis because it's not in the DSM, but they use terminology, kind of clinical terminology, that was the term would either be severe and enduring anorexia, severe and enduring eating disorder. Sometimes it was chronic anorexia or chronic eating disorder. And it struck us that it was used as if it were a diagnostic, like a mental illness recognized in the DSM. But I know from our own research that it's a bit of a we'll call it a developing category. It's theoretical. There's there's even eyebrows going up in that. I'm trying to be as diplomatic as possible. It is not a well-defined or widely accepted construct. So what are your thoughts on that term? I saw nods, I saw eyebrows. What are your thoughts on that kind of terminology? And maybe both, there may be problems with it, and you may also think that there's some good parts of it, in terms of its utility in kind of clinical care. So whoever wants to take that to begin with.
Well, Chelsea, I appreciate your diplomacy, but I don't think you need to be quite as diplomatic. So I think the terminology is probably it probably shouldn't be used. I don't think there's any evidence behind it. And I think the terminology can be quite harmful. I think some people find it validating, and my experience is patients at the height of their illness find it validating with the illness mindset, and that can be extremely dangerous. I think the validating component of it is that clinicians tend to use it in the context of treatment hasn't worked. We've tried treatment multiple times. We're at a stage where we should probably try something different or not try altogether. And so that validates the experience of the patient in saying, well, actually treatment hasn't worked, and that's fair game. I think the conversation should then be, well, what can we do next, other than what we've done already? And one of the issues, and Lorna earlier used when she introduced herself, the term revolving door, and I really don't like that term. I'm not saying that I don't like you using it. I mean, it's what you've used, it's your experience as well, and I think it's important to address the fact that the revolving door isn't a characteristic of the patient. The revolving door is a characteristic of the failed treatments. And so I think one of the things that characterizes the eating disorder field, and has done so for probably several decades now, is that we're not really progressing the conversation beyond psychological treatments. And even though I have extreme optimism and hope when I read the scientific literature, but the interesting thing is that there seems to be a disparity between what's emerging in the science and disparate areas of science, and that probably shed light on treatment pathways and possibilities and hope for patients, and what actually we're doing in clinical practice. And what we're doing in clinical practice is, well, a psychological modality's worked, hasn't worked. Well, let's try it again, see whether it works, try it again, see whether it works. And I think over time that actually contributes to diminishing hope. And so when you're asking about the terminology, I think severity and endurance hasn't really been defined, because we haven't really clearly defined what an eating disorder is, even though, well, we kind of know what it is. And we can talk about that separately, but we haven't actually gotten to the stage where we've clearly defined the two components of that term, severity and endurance. And you can make the legitimate argument that eating disorders in general are actually severe by nature and can endure over time. And so the term that we're using, is that a term that we're defining eating disorders broadly? So does everybody fit that category? Does that then imply that if everybody fits that category, then nobody should be entitled to active treatment? Because I mean, the problem I have is that there's a kind of an implication of using that label, which is that maybe we should step back from active treatment, and that's the dangerous part. And active treatment as defined by what's done already, and I think instead of kind of labeling patients with severity and attributing kind of a time frame after which we're probably unable to continue treatment, is probably a more constructive conversation to have around the actual treatment itself and what components have and haven't been effective and what we can do going forwards. So I think it's a misnomer. I think it's, and I have a lot of my colleagues that do use the term. I don't mean that in a disparaging way towards them, and I don't certainly mean it in a disparaging way towards patients that are aligned with the terminology. I think it's about having the right conversation. So that's my take on the definition.
That is excellent, Ali. I think you have covered what an entire research paper could cover in a few minutes. So that's great. And I'm glad you did it so I could be diplomatic. So Anita, I saw.
Sorry, one other thing, while I have the floor, one other thing that I might add is that one of the things that we do know is children that have eating disorders very early on in life. So we know that, you know, apparently they have the longest length of illness and the most severe the type of illness. What we haven't asked here is whether that's the result of them having had it earlier on in life and before puberty, or whether it's because they've been exposed to more treatments for a greater period of time, and so they're suffering with a different level of complexity.
Yeah. I think you've raised some really important points around, you know, is it a characteristic of the patient? Is it a characteristic of the system? There's so much there. And is the nature of the illness itself, at least in this treatment system, protracted? You know, the nature, it's very hard to, in my experience, to find a patient that hasn't had an eating disorder for more than 3 years. So Anita, I saw your hand first, and then I saw Agnes. So we'll go in order. Oh, you're muted.
There we go. Thank you. Ali, I agree with what you're saying. And you made me think about, you know, the function. I always look at, like, where did severe and enduring come from? You know, I can think back 5-10 years ago, we didn't use it. I don't remember using it the way it is now. And so I was thinking about the label. My experience has been that the label really soothes the system or soothes the clinician. It provides a framework because there's so much, there's such a gap in terms of what do we do and how do we move forward when the traditional things aren't working, that I find that the severe and enduring, or the popularity of it, has this function of creating a framework for clinicians to kind of go, oh, severe and enduring, that's why. And then there's this whole fallout that happens from that. So I've been observing that in a lot of the consulting work that I do. I just wanted to add that piece.
Thanks, Anita. Yeah, I think it's really important. I think that the role, whether we're creating labels that define an actual illness or whether we're doing it to, have a shared language as clinicians, I think is a really important kind of distinction to be aware of. Agnes?
Yeah, I'm probably old enough to remember the origin of the term. So in the group, I think it was proposed something like about 15 years ago in the UK, when there was a government focus on improving treatment for severe and enduring mental illness, and eating disorders were excluded from that. So the idea to introduce this concept was to encourage politicians to fund the services better. And there wasn't actually a clear definition at that point. There was just an observation that some patients with long-standing eating disorders have the same level of functional impairment as maybe schizophrenia, and then these people need help. But unfortunately, the funding never came. And we have been kind of looking at recently a systematic way of the definition, and there is no agreed consensus. There is no definition, so it's a highly subjective thing. And also in the UK guidelines, and James and I have been involved in developing some of the guidelines. It's a very clear statement, both in the NICE guidelines and in the NHSE guidelines, that treatment should be accessible regardless of age, length of illness, etc. So I suppose it somehow crept in, and maybe for systemic reasons, but not because of the evidence.
Yeah, it's interesting too, because you now sometimes see this label being used to actually say, well, this person's not going to benefit from quote curative forms of treatment. So it's been a reversal of maybe that original intention. I saw Lorna, and then I'll go to James.
Just to say, firstly, Ali, with the revolving door patient idea, it's not an idea, it's a practice, it's horrible, but I only use that as a term, really, because I was going in and out of hospital the whole time, because there was no treatment in the community, and I never had my recovery. So that's just to explain why I made that point. But I didn't know about severe and enduring eating disorder. I didn't know that term during my illness. My last admission was it was discharged in 2018. So I think it happened after that, as far as I was concerned. But I was told that I was treatment resistant. So it wasn't, the point was that any help that I was given was never going to work because of my illness and my situation. So there was no point helping me. But that's one point. The other point was there was no help. There was no systematic care. It was just put on weight, discharge you, and haul you back into hospital soon after you relapse.
I'm sorry, I'm
laughing, sorry,
because Lorna was under our care, and I just didn't know that you couldn't be helped, so just as well.
Yes, that's just a bit of context. My last admission was, and Dr. Aiton was my consultant, the final consultant who actually understood me and my problems and helped me get well. So I am well now because of the care that I received from Dr. Aiton.
Oh, that is amazing. And I mean, you have really proven the system wrong, haven't you? It may not have been that you were treatment resistant, but perhaps it was the treatments were resistant to you, or the clinicians were resistant to treating you. I just want to just emphasize that, Lorna, we in our study we found 42% of the cases patients were described as treatment resistant, and because we did that, the study is like a tiny part of the document that existed, even though it's 12,000 words. And we looked at all of the research on treatment resistance, and it crumbles in your hand. There is no meaningful definition of that term, much less any type of evidence that suggests that a person who is, quote, treatment resistant, which is undefined to begin with, is unlikely to get better. So it was really alarming to see that term used in nearly half of the cases to say, this is evidence that this person is not going to get better, thus they are eligible for euthanasia or MAID or assisted suicide, depending on the country you're in. So I really want to underline that. And you see the terminology shift through the years. So you see it go from intractable, treatment resistant. I mean, some of them were, I had a list of them with quotes for a while. So, James, please, let's hear from you.
Sure. I don't know how to follow that really and add much, because I agree with a lot of what's been said, and I think it's very refreshing to be able to have these conversations so openly, in a way that doesn't lead to sort of a feeling of defensiveness, I guess, which I think is something I perceive a lot in trying to raise this subject at all. I relate a lot to your language, Lorna, around being a revolving door patient. I mean, only last year I was a revolving door patient with electrolyte imbalances, and it's just a description of I was going in and I was going out. I think that the problem with severe and enduring eating disorder is that perhaps it's a way of describing, and being used as a description, but it's not actually being used in that way. It's turned into something else. It's been turned into this sort of pseudo diagnosis, and I think that it could be perhaps better to use words that weren't so problematic as descriptors, and to be clear that this is just a description for perhaps the experience that you're having, rather than putting you into a whole category of illness that then transpires it doesn't exist, this category of illness. And I think only through my own research did I realize that, having been called a SEED patient before I even had any specialist treatment, like more, sort of maybe 12 or 13 years ago. And all that time when I was waiting for treatment, I was asking for help. And then to go along to a specialist and they say, oh, you're treatment resistant, when you'd spent 6 years with the system resisting treating you and asking for help, just shows that perhaps of the function of these words is to deflect from the reality on the part of the service provider of, we are not able to treat you, so we're going to evoke a story that this patient is untreatable in and of themselves, rather than address the issue of not being able to treat them. And I think that this is kind of where I covered it from, looking at why do we evoke these things, and what kind of stories does it tell about, what stories sort of are used to justify this, and how does that confine patients, for example, like limiting the possibility that you could recover by not being offered treatment because of some story that people like you are sort of not going to be helped by anything because you've got an enduring illness. And I really don't like the word enduring, because if you look at the etymology of it, it means, well, endure means to harden, and enduring means you have a hardening illness, which kind of suggests that it's inherently progressive. And actually, illness can be interrupted. Sure, it might be getting worse over time because time happens, but not because the condition itself is inherently like a progressive illness. We haven't worked that out. We don't have the evidence for that. And so maybe it's more about the time of not being treated or being ineffectively treated that is the problem than the sort of nature of the illness. Because of course it's not great to be ill for a longer period of time, and that will have impacts. So I don't really like that word. It sort of suggests that whatever we do, there is something about this illness that is getting worse, and all we can really do is maybe slow that down or something, or ameliorate the harms. And I just don't believe that from my own experience. So I think there are alternative words that we could use, like an unresolved illness, or this illness has been maintained over time. These descriptions that don't perhaps have the same sort of linguistic problems and semantic problems. And I just think that it is interesting to think about why these stories have been sort of evoked and why we use the words that we do. I always find that personally really interesting. I can see that it would be validating in a way, but for me, a diagnosis is functional so much as it sort of helps you to access some kind of care or support. With this one, even though it's not a diagnosis, it seems to do the opposite. And just one sort of experience, only a few weeks ago, I went for an assessment with a specialist eating disorder service, and they asked me sort of, why do you want treatment? Why have you come for treatment? And I was like, well, because I'm unwell. And and I have a severe defiant, eating disorder. Well, what does severe mean to you? I was like, well, I'm just using the DSM criteria here, and I come under extreme. And they were, well, what does that mean to you? Because you seem to have a functioning life or whatever. And that, well, it's can we just be sort of common sense about this? And then, what are your hopes for treatment? What do you want to get out of it? And I was like, well, I'd like remission from my symptoms, and I believe that's possible. And the person was like, well, we like to hope that people can get better, but and I think that this sort of like takes this stuff happens, far too often. And I'm wondering, why is that? And it's, I think, because of the systemic carer provider problems, because that care provider is not equipped to provide me with treatment that could lead to the outcome that I want, even though that is possible. But the answer isn't to say it is not possible to recover. And I think that currently that's what we're doing. We're saying that something about the illness, it's not possible to change it. And actually, it's not going to be possible to change it if we don't change what really needs to change, which is with the system and the system provider problems. So that's where I'm coming at it from.
That's great. Ali, I see your hand up. I just want to underline that too. And, obviously it's within that system that that euthanasia and assisted suicide are being offered. So you really can't discount the subtle coercive effects of being told on one hand, oh, we're not sure you're ever going to get better. Maybe remission is possible. We've done all we can for you. And then we do have this way to relieve suffering over here. It's unconscionable, in my opinion. I've lost my diplomatic stance on this. So let's go to you, Ali and Agnes, and then I want to throw another question in for into the mix as well.
Thanks. Just a couple of points, if I may. So first of all, James, I agree with everything that you've said, and I'm sorry that the experiences that you describe. I mean, it's very difficult listening for me because it's certainly not how we would approach kind of patients. It's certainly not the type of conversation that we'd have with patients, nor is it the kind of conversation that I would endorse or advocate for a trainee to have with a patient. If I were kind of supervising them, I would actually take them aside and kind of gently tell them kind of where they've gone wrong and what they should do differently. And point them to some good reading material. I just wanted to address the point, just because it's been brought up by yourself and Lorna, the terminology of the revolving door, and just kind of explain a little bit why I've got a bit of an issue with that term. Not that I've got an issue with people using that term if it fits their lived experience, but I've got an issue with the terminology. And I think that probably is because we're coming at it from two different perspectives. You're coming at it from the perspective of your lived experience, and I'm coming at it from the perspective of listening to colleagues use that term. And to me, it comes across as pejorative, the way that psychiatrists and other professionals use that term. Now, the issue I have with that is that when there are clinical emergencies or patients need care, such as, the kind of what you were talking about, James, going into A&E and asking for care, using that term can automatically exclude you from life-saving treatment. And I have an issue with that. And I've seen that happen time and time again. So when clinicians use the term revolving door, and certainly if I've got trainees that use the term revolving door, they're immediately shut down by me. And it's not because I'm saying I'm not validating the kind of use of the term by people that have lived through that. But what I am saying is that they're deserving of care and they should not be addressed in pejorative terms. and that means a lot to me. So that's kind of the reasoning behind why I was having an issue with the terminology, but certainly not having an issue with either Lorna or James using the term to describe their lived experiences.
Yeah, Ali, can I just say something really, really quickly? Because I do think it is really important. I think that claiming it ourselves as descriptions of our experience is one thing, but like you said, it really illustrates that when these terms stop being descriptions and become about evoking an identity and a story or something about, what this patient is worthy of and this kind of things, and then that's imposed on somebody like, oh, it's this kind of patient. And I think that is really problematic, and I totally agree. And I've experienced that myself, like with these admissions I was mentioning to you, with very, very, profound hyperkalemia, low potassium, extremely dangerous. But the first few times they didn't really take me seriously because I looked kind of well enough. But then it was, oh, it's you again, like, when you're going into the emergency department, or then, every couple of weeks, and you're back again, etc. And then it got to the point where which kind of relates to the work that you've been doing, Chelsea, where a clinician did sort of mention to me there is going to be a point when we're going to have to think about not treating you when you come with very low potassium and cardiac side effects if this is happening all of the time. And I mean, thank goodness that something like that didn't happen or wouldn't happen, hopefully. But it was absolutely terrifying, to me, the idea that in a life-threatening emergency, because I was a revolving door patient, I would be denied that care. So I'm just trying to really support what you're saying, because it is something that happens in reality. It's not just I think it's quite easy in these discussions to say, oh, it's life-threatening, people's lives are at risk, or oh, had this been available to me, assisted dying, I would have chosen it. And for other people to dismiss this as sort of like, oh, that's an anecdote, or this doesn't really happen. But I think, like you said about it denies people life-saving care. Like, this really does happen. And even in those situations, I was deprioritized. And I was very lucky I'm very lucky to be here from that. So it does become very real. These sort of, this language, the story, the narrative, these imposed identities, they do become lived realities.
I just cannot emphasize that enough. I've spoken to multiple parents whose children are no longer here, and part of that story is being rejected from treatment because they're too severe, too complex, too treatment resistant. So I think I'm really glad you brought it up. I want to hear from you, Agnes, and then I'm going to throw another question into our group.
I suppose I'm thinking that we really do need to change the narrative in the field, because if we are kind of comparing eating disorders to other kind of illnesses, within medical practice, we accept that there are first-line treatments, and then not everyone will respond to first-line treatment. And then we have quite a lot of research investment looking into more effective treatments which are more complex. So if we're using, for example, treatment-resistant depression, there were a massive amount of trials kind of looking at, okay, how can we improve outcomes, etc. So I think there is something that we really need to push for, to say, yes, not everyone can respond to first-line treatment, but we need to look at, well, actually, what proportion of people have access to first-line treatment. So is there an issue around funding of services? There's certainly an issue of funding of services in the UK, and I'm hearing in the US as well. But then if people don't respond to first-line treatment, then I suppose our work with the intensive CBT, intensive approaches for a longer period of time, it can make a massive difference to people. And then we also have kind of new potential research areas. So we really shouldn't be going down in this rabbit hole of palliative care or end-of-life care or MAID or whatever else you call it, because we really should be kind of thinking, well, how can we improve services?
Yeah, you've given me a perfect segue to my next question, and I think I just want to also acknowledge there's been some really meaningful shares in the chat that have spoken to some of this. One person shared that after being told that she was a seed patient by Zoom on by a virtual meeting, her care was given to hospice, and essentially the eating disorder team took it to mean that they no longer needed to see her. And I think there's such an important role for palliative care in its exceedingly rare cases, but I in no way want to say that palliative care is bad or any of that. Like I've worked with patients who are no longer here, so there may be, an important role. I want to be really clear not um, to be negative toward palliative care and eating disorder care. But I think what you're speaking to, Agnes, there, and what that person just spoke to in the chat, is that it's almost being used as a replacement for care, for treatment. Not almost, it is. It's going, oh, well, these treatments aren't working, and thus palliative care is all we can do for you. It's not being used in the way that palliative care should be used, which is to reduce suffering in a person who's dying, that it's completely being misappropriated in this context. So that really brings me to a question that's really at the heart of our conversation today. And then I want to just say to the audience, in about 5 minutes, we're going to start taking audience questions. So if you have some, please feel free to drop them in the chat, and I'll go for them. But one of the reasons this term that you all have been speaking about exists, I mean, you've spoken to some multiple reasons it exists. It's Agnes, you said earlier, it was conceived in the UK to help get access to funding for care, right? And I think, Anita, you spoke really beautifully to it has been used, it might exist in part to give clinicians a shared language for speaking to one another about their experiences, whether appropriate or not appropriate. So there is a reason it exists, and I have to think, if we think of the best of intentions, if we try to give them really give the benefit of the doubt here, it may be to recognize that there are a number of patients in our system that are not being served by standard treatments, or the treatment that they're being offered. So, and not, that might be being overly generous, but go with that. So I want to ask you, what in your clinical experience, your lived experience, what do you think are some of those needs that are not being met in our current system? What are some ways that we can better serve individuals who have been fighting to get better in this system for a long time? Again, I know you could write multiple papers on this, so feel free to just, okay, James, I see your hand.
Sure, yeah. I mean, I think there are so many things that could help people more. And I think that's what I'm almost more interested in, is about, well, what does help? Because the frustrating thing about being told there is nothing that can help, or in my recent treatment with an eating disorder service, where they say nothing seems to help, I was kind of like, well, in my experience, whilst I'm not recovered, there have been loads of things that have helped me, and what I want is more support to structure and scaffold those, and to do them to keep improving my health. So there are loads of things that can help, and we need to put our efforts there rather than things don't help. And I think from my own experience, I would probably say that I think that weight and weight status and nutritional status is extremely important. I think a huge lacking component is the sort of psychological support to deal with that. Often it seems to be, well, this is just my own experience, I don't want to speak for anybody else, but not having the psychological support alongside weight gain and rehabilitation nutritionally is a huge error. And I think that can leave people feeling worse in their own skin sometimes than anything. And that could make the prospect of being healthier an undesirable one, So I found that what did work for me then was having dialectical behavior therapy when I did weight restore, and I found that really helped me to cope with all these new feelings that were coming back into my body after being starving for such a long time. And I think that it's a shame that not more people have access to that. The other thing I'd say is really, I mean, there are so many things, but I think I'm, from my own experience, looking at the whole picture of somebody's presentation with a particular emphasis on the biology, because I have the other co-occurring conditions. And I think that sometimes it's been easy for clinicians to see them just through the lens of an eating disorder or through the stereotypical view of an eating disorder. Gastroparesis is something I really struggle with. So my stomach doesn't empty very well. And that predates my eating disorder. But the sort of imposed story of this is anorexia meant that that was unrecognized and untreated. And I think actually I started to perform elements of illness with anorexia that I didn't have when I went into specialist services, which is a really sort of harmful consequence. And then what it looks like now for me to recover is completely different. And what I've been a lot better recently because I've been having a liquid diet. That's not normal eating, but that's something that's really, really helped me with my nutrition, with my blood sugars, all this kind of stuff. And I think that when I was being pushed to sort of do normal eating, was when I was having all these admissions to hospital. My stomach wasn't coping and it was making me a lot worse. So without that sort of bigger picture knowledge, I think that we're sort of operating in the dark a little bit. And it's not unusual for people with eating disorders to have multiple other conditions, whether that's psychological or physical, or whether it's even helpful to divide between the two. So I think that that's where I'm really enthusiastic about psychiatry in particular, as a particular identity that holds all those different, role that holds all those different parts. And also just personally, the medicalization of my illness is something, when it comes to language, that I really don't have a problem with that idea. I know some people do, so I'm not speaking for anybody else, but I'm kind of like, please medicalize me, because I have found it very helpful when people have.
Wow. Yeah. Thank you, James. I think you speak to really the importance of individualized care, if and recognizing that an eating disorder may be one of many things people are struggling with, and they may compound on one another, and it may be very difficult to treat the eating disorder without treating others. Alia, so your hand come up, and then Lorna.
Well, I completely agree with everything that James. Oops. Okay. Yeah, and I agree with everything that James has said. And I kind of just want to add a little bit more to it, because the idea of nutritional deficiencies and eating disorders haven't been addressed in the right way, in my opinion. And I think one of the problems in the eating disorder field is that we've probably been frozen in time for a very, very long time, and we're thinking about psychological treatments. And I think if we're having a discussion again about language, I think it's probably a misnomer, because psychology is incredibly supportive, but it's not a treatment. And so that we probably need to kind of address that terminology as well. But I think that there are multiple things that haven't been addressed in the eating disorder field, and there are multiple treatment pathways. And the fact that we're dealing with a disorder of malnutrition predominantly that leads to psychiatric consequences, behavioral and emotional kind of symptoms, is an extremely important distinction. Because what we often conflate is the consequences with the disorder itself. And so the disorder itself is not its consequences. The eating disorder psychopathology, the so-called psychopathology, the emotional and behavioral components of the eating disorder are consequences of nutritional inadequacy. And that's not because you've got a kind of a deformity in your brain that's making you have thoughts about your body image. Those are consequences. And so if we ask the question of what actually is causing these eating disorder in the first place, physiologically, it's an alteration in appetite signaling. And again, language here is really quite unhelpful, because in English we use the term appetite to describe something different, which is our experience of gravitating towards food or not gravitating towards food. And physiologically, when I use the term appetite, it's our body's ability to signal to us intuitively its nutritional needs. And in eating disorders, there seems to be a kind of a disconnect between the body's ability to communicate nutritional needs and then us acting on those nutritional needs accordingly. And that can happen because of one of multiple factors, right? I mean, it can happen because of your neurology, so neurological circuits being responsible for that, and appetite regulation is there's a well-defined body of literature that talks about that. There's there can be structural abnormalities in the gastrointestinal tract, and James was talking about that in gastroparesis. There can be inflammatory disorders. There can be a whole host of different things, hormonal disorders, but not necessarily just disorders. But there are things that that aren't working quite as effectively, that don't reach the threshold of being a disorder within any one of those domains, whether it's neurological, whether it's biochemical, whether it's hormonal, structural, that contribute to patients having genuine symptoms. And I think addressing all of those things is extremely important. I think a lot of patients with eating disorders, unfortunately, have multiple unrecognized conditions. But if we took the time to recognize those underlying conditions and address them, then it would probably help. But that obviously doesn't mean that we don't do so within a psychological framework, because that's extremely important.
Yeah. Yeah, I think you've both spoken really well to the fact that eating disorders don't exist in a vacuum. You know, there's many things going on. And then I think also you've spoken to how urgently we need research in this disorder. You know, the funding for eating disorders is a drop in the bucket compared to other conditions. Lorna, let's go to you, and then I've got some great questions. I've got actually a question specifically for Anita that I'm going to go to next. So
Okay, just to really back
yeah,
up what James and Ali just said. So for me, what helped my recovery was having care for the whole package. So my situation is, every situation is complex, and it has many different avenues, but I have multiple comorbidities, and it began from the eating disorder started from a brain injury. And then I'm also going to throw in a can of worms, which is personality disorder, because being diagnosed with a personality disorder, is that actually correct? And that has an enormous stigma and discrimination medically when you're given that terminology. I think having access to care which supports the whole package, and also it supports you during the journey which you've taken during your treatment. For instance, I had a lot of difficult times over the years, not because of my illness, but because of the treatment that I received during my recovery. So I needed help in the end to deal with the trauma I had experienced in treatment. So that shouldn't be forgotten. That needs to be taken into account.
Yeah. Iatrogenic harm is what you're speaking of. I sometimes think about treatment as the nicest way to put it is it's almost like re-breaking an arm sometimes. And I mean, very often they never actually put it back together, but the treatment system itself can be, and you know, I was lucky in that they actually put my arm back together after re-breaking it in a horrific way during the treatment process. But I think that's so important. Laura, we've got some really good questions. I also want to underline what you said about personality disorders and just again tie it back to our study. There, nearly half of the patients in our study had personality disorders, mostly borderline personality disorder, at least in terms of what they were diagnosed with. And you know, we have issues with our diagnostic systems and how we characterize these things. And in the larger body of research on psychiatric euthanasia, because most of it's been done in the Benelux countries, personality disorders are highly represented in, and specifically borderline personality disorder in people who are seeking euthanasia or assisted suicide. So it's a huge problem. There's been some great research by our researchers, Nicolini, who's done some great reviews on the topic. And this is a good segue, I think, to a question I've got a few here, but this one is for you, Anita, and it's one that I really want to know the answer to as well. And it's related because it's about dialectical behavioral therapy, which is, you know, was developed by Marsha Linehan, really actually for the purpose of helping people who are suicidal. We think of it as borderline personality disorder. She got routed into that because that's where the funding was, but she was interested in supporting individuals who are chronically suicidal. And it's something you specialize in, Anita. And this question is, could you speak to how DBT can be adapted specifically for working with individuals who have had their eating disorders for a very long time or dealing with a very severe form of the illness?
Yeah,
severe illness.
It's a great question, and it's where I really sort of my career has been, is adapting DBT. So we actually, our book is coming out hopefully in 2025. And so the issue is that we have something called MedDBT. So one of the things that struck me about the paper that you published was exactly what you and others are saying in the chat, is the substantial amount of people with co-occurring difficulties, most of which are not treated or have never been treated. And then when I work with many, many hospitals sort of internationally and different organizations, most of those providers don't feel comfortable, often get easily burnt out, feel frustrated or ineffective when people have more than the eating disorder. And so, you know, that really grabbed me in the paper. And so MedDBT, with the M is for multi-problem or multi-diagnostic, for lack of a better term right now. But it is designed for people who have an eating disorder in the context of other co-occurring difficulties, whether that's suicide, self-injury, trauma. And what we have found is that the more dialectical we are, which is, you know, the treatment itself is not just focused on the eating disorder. So we say, you know, your eating disorder symptoms are a significant thing that we have to look at, but it's about the eating and it's not about the eating. It's about your weight and it's not about the weight. And so we've developed an entire treatment that looks at the biology of the eating disorder. So as Ali was saying, we look at the, you know, everything from Cindy Bulick's research looking at metabolic factors that contribute, but we also look at emotion regulation factors that stem from biology and biotemperament. And the treatment is designed to focus on the eating disorder in the context of your biotemperament and all of the ways that our clients have been invalidated. So we, you know, a lot of people are talking about the trauma they've experienced within the system. That is a core part of the treatment. We look at how they have evolved and how they have learned to cope, trying to manage systems that completely invalidate their experiences. And so that's sort of in a nutshell. I mean, there's so much to say about it, but I feel very hopeful about the research that we already have around MedDBT. The problem is, and people write to me on social media a lot about this, is they say, that's great, Anita, that the argument is we need better treatments. But they say, but what happens to those of us who sit here right now? We're never going to access MedDBT anytime in the next year, or MedDBT is only available in the private sector, at least here in Canada. So you need quite a bit of money to actually access that because it's not part of publicly funded systems. And in fact, my efforts to get differential care pathways into the system have been minimized and actually rejected outright, at least here in Ontario. So I've seen some comments about Ontario here. And we're really stuck with people who are really in pain and say, that's great, I would love to get that treatment, but I can't. So what happens to me? And that I just wanted to make sure that we weren't having this conversation without recognizing that group of people watching maybe, or will watch this and say, that's nice and idealistic, but it's not my reality. And I personally struggle with, what do we do there?
James, I saw your hand go up, and I feel like you can speak to this issue really well. Yeah.
Nodding along vigorously, because I have exactly that same question as Anita. Sort of, well, what about the people who don't have access to this knowledge, like listening to Ali saying, oh, if I was supervising somebody and they said that to you, then you'd pull them aside. But I think this kind of experiences that I've had of, you know, poor care often, or just profound neglect most of the time. Now, this is commonplace for most people, because I think a lot of, you know, the tiny minority of people have any help at all. And then is it very, you know, helpful, or does it cause all these harms that Lorna's also talked about as well? And I think we have to bear that in mind throughout. It's interesting that we brought up personality disorder, and I think that for me, like, I find it's a very stigmatizing word. It's something I was diagnosed with in the context of extreme, like, medical instability, chronic sort of neglect and harm from services and things like that. And I think as a description, it really fit my problems. It was that it came with all this extra sort of stigma and labeling and all kinds of horrible connotations, pejorative, like you said. But the function of it was that it gave me access to care that really helped, which was the DBT. And I think that DBT, for me, I'm a big advocate of it, probably because it really helped me. You know, there's my own bias there. but I did like how integrated it was, even the kind that I had. And it wasn't that it really spoke explicitly to the biology, but it's because like med DBT does, which I think is fantastic. I think it was because it sort of was maybe less direct, but it's fundamentally an embodied approach. It's not dancing around and doing yoga and this kind of stuff that I love, but it is mindfulness based. And I think that it really sort of addresses this question that I have often of, well, what's the role of the body in eating disorders? And like we've talked about biomedically, but I'm also talking about the experience of being a body moving through the world with all these feelings and sensations that maybe are not well regulated or are completely intolerable and can't be existed alongside. And how do we find a way to exist with ourselves in our embodied experience, not a starved experience where we've dampened it all down, or like when I regained weight, a really erratic sort of experience where the peaks were even higher than before I started starving. So I think that this question that I have of, you know, what about here in the here and now? Because I love hearing about the biology, and I think that's so important. There's so much that we don't know that we'll have hopefully loads of answers for people in the future. But in the here and now, we don't know that stuff, and we don't have that sort of integrated care. I see you've seen this eating disorder people, and they're like, oh, well, you've got to see the gastro. The gastro says it's an eating disorder. Don't see me, go and see the eating disorders people. Well, what about that person in the middle, in the here and now? What resources do they have, whether it's called psychology or whatever? I'm kind of like, are there some practically helpful things for people in the here and now that can help them to exist a little bit better, and then directing towards recovery, how that's defined. And the last point is that there is so much complexity. I think complexity is the norm when working with people, so I don't see why it's especially complex here, and why then we need the word or the label of complex, like you said about severity, Ali, as well earlier. So if we just think that complexity is the norm, we don't have to label patients as complex. And I think people who want to go into working in this area hopefully are signed up for the idea that it's complex and interesting.
Mm-hmm. Yeah, Ali, I want to go to you, and then I've got some really good audience questions, so I'll go to those next. But let's hear from.
Well, yeah, okay. Well, thanks. I'm very keen to hear the questions. I think that's really important as well. But very quickly, just to address the questions that Anita and James were kind of asking at the end of their statements by saying, kind of what can we do right now with people that are actually struggling in reality? And I think that one of the things that probably we need to ask ourselves is whether we need to remove the monopoly that we have as a subspecialty over eating disorders, considering the fact that we know that it's kind of there are all these components, and patients often present to every other service, not a specialist eating disorder service, whether it's out of hours emergency or whether it's kind of indirectly family doctors and GPs or in any other context. And so I think one of the things that we need to ask ourselves is whether it's reasonably sat in a psychiatric specialty, or it should be a case that every medical doctor should be equipped to be identifying, acknowledging, kind of diagnosing and treating and appropriately assessing eating disorders, and doing so competently, rather than saying, well, actually it's a specialist area and delegate to a specialist. I think increasing investment in training doctors with a specialist expertise in eating disorders is a failed enterprise. I think eating disorders have so much, not just physical consequences, but kind of physical co-occurring conditions, that it's extremely important that every doctor working in every specialty is able to recognize, but also treat. I think we should probably change expectations as well. And I know that some people will kind of say, again, it's, this is aspirational talk in a panel, but in reality, it's not quite the same. But I do think we need to be changing our expectations. I think it's not okay for treatments to kind of take an inordinate amount of time before you see an outcome. I think we should be expecting outcomes in a much shorter time scale. So that's my piece, but I'm very keen to hear questions.
I am so glad that we heard your piece. I didn't mean to. I'm more like dropping markers just for all the panelists, and I'm so glad we heard from you on that, because I think what you just shared is so important. in this context. I think all of what you Anita, James, and Ali, I think Ali, you spoke to the fact that we have a system in which, James, you just said in the chat, eating disorders have become hyper specialized. So our healthcare system is not well equipped to treat. And sometimes the eating disorder specialty, not to be unkind, but is not very well equipped to treat the patients that we have. And I've learned through this conversation, have a very insular community who sometimes against evidence has decided that, terms like severe and enduring eating disorder should be used to determine clinical practice, or that euthanasia is appropriate for people with eating disorders. I'm really glad you spoke to that. And the only other thing I wanted to say there before going to this question is, it kind of is a segue to it, is that we're doing a webinar coming up with the disability rights advocates that have been part of our statement, talking about the intersection between disability and eating disorders and the common risks that both of these communities are facing with the legalization of assisted suicide and euthanasia in many countries. And one thing that an advocate in that community said to me, she said, it's precisely these reasons that you have spoken to, Ali, James, and Anita, that our system is so flawed. And she was talking about it in a disability context. It's precisely for these reasons that they are concerned about the legalization of assisted suicide, because all of these issues in the healthcare system puts people into a very vulnerable place where they can't access the care they need. They're getting poor care, and assisted suicide begins to feel like the only option, or euthanasia begins to feel like the only option. It is the very reason we have to be very concerned about this, not our system is bad and thus it's okay that this. Does that make sense? Like, I think that somehow we're in a reversed way of thinking about it in the eating disorder community. Agnes, is it okay if I float this question and come straight to you, and you can both say it and answer these questions? Okay. So this is a really an excellent question. I'm going to give it with a comment. So there was a comment here in our chat that said, at times I wanted help dying, but at others I wanted to be left alone to die, which is complicated, but also paradoxical in the way that an eating disorder can be. So I'm going to offer that comment. And then the question came from a different person, is nearly all assisted dying is embedded in the same healthcare systems that have a nihilistic view of eating disorders. Does that increase the risk that an assisted death becomes an option for an eating disorder? So we'll go to you first, Agnes.
Well, I suppose my comment is related to this question. I was kind of thinking that feeling suicidal is a temporary thing. So I have been working in psychiatry for 40 years, so 25 with eating disorders, and also worked with neurology and people with chronic and progressive illnesses. And I think most psychiatrists would agree with me, actually, that people feeling suicidal is something that people can go through and can come out of it. So it's a temporary thing. So I can't understand for the life of me why we are talking about medically assisted suicide for people with any mental illness or eating disorder. Why is eating disorder any different?
I totally agree. Yeah. Anita, I see your hand.
Oh, it's making me think. I do agree with the idea, like, why is this such a big issue in anorexia? Because that's where terminality has originated. Why aren't we seeing this across all? Then it should be the same for depression and bipolar disorder and schizophrenia. Like, it's interesting to me that it's eating disorders particularly that is getting this. I understand it's in other conditions as well, but I haven't seen it quite like I see it in eating disorders. And then I thought, Agnes, I was thinking about your comment, and I know what you mean by suicidal thinking or urges are temporal. They ebb and flow and shift. And yet I think a lot of my clients would say, but it doesn't feel like it goes away. Like it's just there. It's haunting. The intensity might shift. And I think for some people it's exhausting to move through life always feeling so awful, and having an eating disorder, and being invalidated, and having a trauma history. And death becomes the ultimate way of coping with it all. And it's very hard for them to imagine a life without that. For some people, that suicidal thinking is the way that they've survived. And so I know what you mean by temporality, and I want to be mindful about how awful it feels for our clients to exist as they do in the system as it is. And sometimes clients will say to me, yeah, it's nice for you to say, I shouldn't feel this way, or I'll get over it, or just use your skills. And then how invalidating that itself ends up feeling sometimes for clients. And I want to hold space for that too. I just wanted to say that.
Yeah, I love that you pointed this out, Anita, because I also am befuddled by the fact that, it seems to be that anorexia specifically and eating disorders more broadly is the first frontier for this small side of the wedge for assisted. And maybe it's because there's a physiological aspect, and so people go, okay, well, but I wonder if, the person who asked this question is onto something. If there is a level of stigma even within the system itself, where they go, well, these people really are just untreatable. And I don't use that language lightly. It was all over the case statements. It was all over them. Untreatable, chronic, no prospect of improvement. If I read that sentence one more time, I will, throw something. Ali.
Yeah, I'm pleased Anita is also holding space for that narrative. I mean, I was quite taken by the first question that you read out, the person kind of expressing the ambivalence that they've experienced with, at times, genuinely feeling suicidal, and others not so much. And I think it's I mean, well, I think there's a couple of things to point to. The first is that I completely agree with what Agnes is saying in terms of the duration of it. Now, unfortunately, with a crisis of nutritional deficiency that causes these kind of alterations in our thinking, in eating disorders, because of, I suppose, the severity of it and because of the degree of malnutrition, it tends to be protracted. And so there's a long duration of, usually crises are short-lived in eating disorders. There's a crisis that's kind of happening over a genuinely long period of time. And I suppose for people that are experiencing that, it feels like there's no end to that. But there is, and it's entirely irreversible. But it takes time. And I suppose therein lies the kind of conundrum in and the ambivalence in the eating disorder mind. I want to talk about the concept of assisted suicide is really quite concerning to me from multiple perspectives. But the image I have in my mind is a patient who's suicidal, kind of standing on the ledge, and you as a clinician standing beside them, and it's been a long time, and they're wanting to jump and not jumping, and then you eventually say, well, look, we've been here for hours, days, we've been here a long time, we've done everything that we possibly can, we've given you psychological treatments, we've given you all, well, is it about time that maybe you should just go ahead and jump? That's the conversation that we're having with eating disorder patients. And I think it's important that we put it in context of the crisis that the patient is experiencing in the moment, and the moment is probably longer than what we normally would define as a moment, is completely resolvable. And we need to be able to hold space for the ambivalence psychologically, but also stay with people and support them throughout the process to get out of that mindset, and both support them psychologically, but also medically, so that their brains are able to recover in such a way where they're able to shift their thinking in a meaningful way that takes them out of a suicidal kind of frame of mind. But to respond to a crisis situation by kind of raising our hands and saying, well, we've done everything that we possibly can, and it's about time that maybe we call it a day, is well, I mean, I suppose there's no other way to put it other than it being inhumane, but also medically negligent. And I think it needs to be kind of called that. Otherwise, I don't think we're being kind of reasonable with ourselves about what it is that's happening. So, yeah.
I am so glad. I'm so grateful that you've stated that in the way that you just stated that, Ali. Yeah, I think when we dress it up with medical clothing, it somehow sanitizes it and it feels a little bit more legitimate. But obviously there's a difference between jumping off a bridge and taking a medication, in terms of, but even the medications that are used in many countries have not been tested. So you can't even go that route of, oh, it's a better route to suicide. We are talking about the providers that until that moment had been responsible for preventing that person's suicide, then aiding in that person's suicide. So it's really, I think I'm so glad you named it. We're down. Oh, James, is your hand up? Let's go to you, and then I think I have a good question to wrap us up.
Yeah, I just one thing I want to say, and then I have to run and get a train.
Oh, okay.
But it's just a very difficult conversation, but a necessary one, I think. Just difficult subjects, and I think that I've just been reflecting on the last two comments and things. I personally am somebody who lives with suicidal thoughts pretty much every day. It's always kind of there. It's very unusual for me to not have some form of suicidal thinking or suicidal, whatever kind of way you want to think about this. There aren't really days like that for me. And I can coexist with that and have some kind of peace with it some days, and some days it's more difficult. And the context really shapes how I experience that. And so some of that context can be biomedical, like we said, like with the low potassium, just using that example because I used it before, I am suicidal. I have a personality disorder with a chronically low potassium and all the experiences that I have then as a description. Those are the behaviors that I exhibit. And then if I'm adding into that a traumatic experience in life or insecurity in other kind of ways, or all these other factors, contextual factors, or a system that's not wanting to treat me, then it increases and it increases. And what are the options out of that situation? And sometimes I think our context can be very binding. Now, we want to create contexts like healthcare that you go along and it will help change that and untangle all these maintaining factors, the biology, the sort of other social factors, and loneliness, isolation, a huge one. And I'm just remembering my own not too recent experience, which made me move across the country to be back with my family, and that saved me from a context where I did really I really did want to die and then end my life, and didn't see that it would be any different, apart from I was privileged to be able to have that huge contextual change, and not everybody has the privilege to go back to a family home or something, or to, and it was a gamble, and it really worked out for me. And I just sort of think that we have to hold all of these things together when we're talking about this, that there is a hypothetical sort of possibility that things can change, but sometimes the experience of wanting to die in different forms can be very sort of, very long standing, whatever word we want to use for it. And I suppose both can be true, I guess. And I don't know if that's very useful. I don't think it's just about mindset. For example, the mindset, like you said, product of all these different factors, and ones that we haven't talked about, like the social isolation, the sort of economic insecurity, these kind of things, and other harmful experiences. So I just wanted to mention that, really.
I'm really glad you did, James. And we're coming to the end here, so I know you have to go for a train. Can I ask just maybe in one sentence for each of you, just to close this out, if you were one practical change you would like to see and I know you can do a big sentence on this, one practical change you would like to see that would improve some of the things we're talking about in the system, it could be anything.
I can be quick because I may have to vanish. I would say just more compassionate, non-judgmental stance from people you're seeking help for would be incredibly helpful, and that should be a given, not an exception.
Excellent. Thanks, James.
If I can go next, what I would say, if I'm going to choose one thing, is that we probably need to reorient ourselves in terms of the questions that we're, specifically research questions that we're asking, and ask those questions in collaboration with people with lived experience. And I think that what we do is delegate the asking of those questions to scientists, researchers, and clinicians. And they choose what they think is kind of top priority to research, and that dictates what happens in terms of clinical practice. So I think that involving people with lived experience right from the outset, asking the appropriate questions, actually putting research into practice, and then overseeing that quality assurance, and actually working in collaboration with those with lived experience, I think is extremely important.
Agnes, Anita.
Shall I go?
Oh, sorry.
Oh,
I was going to say, it's really important to have to listen to people and hear what they have to say, listen to people's stories and hear their lives and what's going on behind the scenes. So I think if anything could change, it's really to have an opportunity for someone to be there to listen to you. Whether that's probably within the mental health team, or it could be just in the community. So services in the community.
Anita, do you want to go next?
Sure. I'm trying to think of how to sum it up, but I think that continuing to work together, like even just looking in the chat, I sometimes feel like it's hard to create change. I often use the I feel like I'm sort of swimming upstream, and then I come to things like this and I connect with people who have similar views and ideas. And I think part of change has to be in connecting and creating voices that speak together. I just don't think we can do this alone or in isolation. I really think that all of us, researchers, clinicians, those of us with lived experience, I think the more we come together, the more inspired I get. And I feel like it's actually possible in ways that I know I can't do alone. So there's so many things we could do out of this. And I think continuing to connect is very, very important. That's what I would say.
I suppose from my perspective, we need to work together with policymakers to improve funding and training regarding eating disorders, because it's been kind of ignored internationally. And they do need to understand the human suffering, and they also need to understand that people with eating disorders have a huge amount of contributions to make to society, and they deserve, I suppose, appropriate and effective treatment.
Yeah, you all hit on all the points. I love what you said. I love that you landed there, Agnes, because there's a bigger system that is going on here, and it does sometimes feel like we're working upstream, and part of that is related to what's happening, in our communities that are within our control, and a lot of it is really coming from the top down. And I'm also really glad, Anita, that you ended on that note of how important it is to come together and to have these conversations, because it can feel you can feel really lonely in this work. I can speak for myself at least, plugging along on that research paper. Thank God I've had Catherine, my co-author, but we can feel really lonely and isolated, and every country is dealing with different problems. But I'll tell you what, they're not that different. Speaking to someone in Germany last night. So I think it's really important we continue to come together. I want to thank you all for coming together, both our panelists and all of you who are here today, and let you know that we are not stopping. We've got a panel discussion coming up, really looking at the risks that assisted dying laws pose to both the disability and the eating disorder communities, and the overlap there, because a good number of our the cases in our study were people that were disabled as a result of their eating disorder. And we've got one that is on the docket. It's not on the site yet, but I'm really excited about it. We'll be in partnership with Feast and an organization in Germany that translates to Hungry Hearts, and an organization in New Zealand called Eating Disorder Carer Support, looking at the real issues that are facing families when they have loved ones who are not being served by this system. And it's heartbreaking and so important. So I'm really excited about that. And then I think I've got a couple more coming down the pipeline. So please stay tuned. We'll send the recording of this event to you afterwards. If you're watching it in the future, hello, thank you for watching to the end. And we'll end it there. Thank you all so much.
Thank you.